Neurology quiz number 2. How does MuSK positive myasthenia gravis differ from acetylcholine receptor antibody positive myasthenia gravis? Antibodies to MuSK are found in 8 to 10% of myasthenia gravis patients. MuSK MG is commoner in young women. It can present with typical features of myasthenia gravis. However, many patients have atypical clinical presentation with prominent involvement of the neck, shoulder, and respiratory muscles, and also have fixed weakness and atrophy of bulbar and cranial muscles with little or no ocular involvement. Such patients can be mistaken for muscle disease or conditions like ALS. Thymic hyperplasia and thymoma are rare in MuSK MG, and thymectomy has no established role in MuSK MG. Rituximab has been reported to be highly effective in MuSK MG and can be considered as an early therapeutic option, while in acetylcholine receptor antibody positive MG it is indicated in refractory cases. MuSK MG patients can be sensitive to pyridostigmine and become worse or develop diffuse fasciculations even after small doses of the medicine, and it should be used cautiously or discontinued. What is the O'Sullivan sign on a brain MRI? This sign is seen on brain MRI in CADASIL. It consists of T2 hyperintensities in the anterior temporal poles and is seen in 90% of cases. This location is usually not involved in other causes of white matter disease such as hypertension and diabetes. Other characteristic sites of white matter disease in this condition include the external capsule and corpus callosum. Also seen are lacunar infarcts and leukoariosis. MRI changes precede clinical symptoms and can be used to screen pre-symptomatic carriers. Clinical features include strokes and TIAs, cognitive impairment, and migraine. The clinical and radiographic features may be mistaken for MS. Diagnosis is confirmed by demonstrating a mutation in the Notch3 gene on chromosome 19. These are examples of hyperintensity in the temporal poles, or the O'Sullivan sign. What are first-line drugs for treatment of infantile spasms in children? Corticosteroids, either intramuscular ACTH or oral prednisone, and vigabatrin are the agents of choice. Vigabatrin has higher efficacy in cases due to tuberous sclerosis. For other etiologies, steroids are usually first choice, and IM-ACTH is preferred over the oral route. The major side effect of vigabatrin is retinal toxicity with constriction of the visual fields. This is dose-related, and for this reason, doses more than 150 milligrams per kilogram should be avoided, and the medication should not be given for more than 1 year. What is dumb rabies? The majority of rabies patients present as furious rabies, secondary to encephalitis, with fever, agitated and excitable behavior, hydrophobia, aerophobia, circulatory failure, and death. Dumb rabies or paralytic rabies has a slower course with progressive paralysis of the limbs, respiratory failure, coma, and death without an initial furious phase. It is seen in about 20% of patients and is commoner after vampire bat bites and in those who have received post-exposure vaccination. Peripheral nerve demyelination is thought to be the underlying pathology. This type can lead to considerable diagnostic confusion and is mistaken for other causes of rapid paralysis such as GBS. What are the causes of sensory neuronopathy? Sensory neuronopathies or ganglionopathies are characterized by primary and selective dorsal root ganglion neuronal destruction. Prominent clinical features include disabling sensory ataxia and widespread areflexia. Causes are paraneoplastic, most commonly associated with small cell lung cancer and anti-Hu antibody, autoimmune such as Sjogren's syndrome, toxic, vitamin B6 toxicity, drugs, commonly platinum-based drugs such as cisplatin, infections like HIV and VZV, and idiopathic.